What's up, everyone? How are you doing? Hello? 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 Anyway, I just wanted to come on here and we're gonna go ahead and get into this video that I'm about to make right now, currently um, on April, what's today? Today is April 14th. Today's April 14th, and your girl Lil Desi is about to give you a lesson. So today, class, we gonna learn about general surgery. So let me just give you a rundown. Hi, my name is Desiree Marissa Lee Thompson. I am inspiring to achieve my goal, and that is to take my boards within 2 months from today. I gotta scratch my arm. I have been studying since 2022. I think I've been studying for a minute. And I I became very intimidated by the task, and I got overwhelmed by it. I even got negative with me being someday a certified surgical technologist. I did go to school. I did get my credits, and um, back in 2021, 2022, I have not been in the OR for almost 4 years, 2 years. So, with that being said, I am here today on April 14th, 2025. I am single. I am in the master's house, which is the memorial um, for my job. And I'm making this because this is something that needs to be done. I posted a lot over the years as a dancer, an actress, a model, a comedian, you know, even motivational speaker. But I'm going to step into this position today and introduce yourself and to reintroduce myself. So I hope you're ready for this lesson because it's one for the books. It's it's general surgery. One of the longest chapters in the text, in the textbook. So I'm going to scoot on up in this edge of this chair because I need to make sure I'm giving good, accurate information. Now, I will admit, this is going to be fun. Okay, so here we go. General surgery. General surgery. Should I get the book? Just to give you like a rough. So this is the book here. Okay. This is the book, it's Principles and Practice for Surgical Technologists, edition, 8th edition. By, who's this by? Joanna. By Joanna, you see the name. Okay, I put it by Joanna Filler. I'll put it down in my description so you can be able to find it. But all right, so general surgery. Let's go from the front page, and we can get that chapter right then and there. So a surgical technologist, while I'm doing this, is responsible for distributing instruments and following the standards, guidelines, and the concepts of sterilization. I'm trying to find general surgery. I don't know why I can't find it. Decontamination, sterilization, and disinfection. So, what made me want to become a surgical technologist? The truth is, I wanted to go for my RN instead of my AST. But I had setbacks and moments when I was in college that I had to withdraw myself. And that really dropped that opportunity in a sense. I am currently re-entering that, going back for my RN, but I don't know. We'll see. So general surgery. Hold on, because I'm having okay, general surgery. I'm going to give you a brief representation of what general surgery is. It's pretty much sorry guys, if you can just give me a second. We're in class right now, so if you don't got the book, you need to get the book. General surgery all the way back here. Dang, general surgery is long. That's robotic. I'm like, dang. Okay. So general surgery in the Principles and Practice textbook would be on edition, the 8th edition will be on chapter 22. In chapter 22, you'll find everything that you need to know if you are studying to be a surgical technologist. So briefly, general surgery is okay, first of all, you need to know the anatomy. Okay, it's because with general surgery, you're working with a lot of the okay, let me rephrase. So with general surgery, you are involved in organs and organ systems. And these are the abdominal wall, the gastrointestinal system, which is considered the GI, your biliary system, which is your gallbladder and your associated structures, your spleen, your pancreas, your hepatic system, your breast, and your thyroid. General surgery is very interesting because with general surgery, I found as a surgical technologist that it's really about anatomical positioning and knowing your anatomy, like I said. In this subject, we're going to talk about structures, a lot of the structures of the abdominal wall. And we're going to go over the specific elements in case planning for the abdominal wall hernias, including and the instruments used in these surgeries, along with the repairs materials that go into the surgery. So with abdominal surgery, the organs and the organ systems involved in the abdominal surgery include the abdominal wall, the gastrointestinal, the biliary, which is your gallbladder, your spleen, your pancreas, and your hepatic system. Question: why is it useful for a surgical technologist to understand the body quadrants? So that's your anatomy, knowing your anatomy, knowing the quadrants, and knowing that you need to know this because of your systems, because your anatomical positioning is, this will always be considered your left and this will always be considered your right. Okay, so no matter what in anatomy, in surgery, left, right, okay, you know that your right upper quadrant, you have your, you know what organs are in place, right? So what are some complications that could occur if there was a wrong incision, right? If you did not know what organs are placed in your right upper quadrant or your right lower quadrant, you can punctuate, I can't say it, puncture an organ. And this can be a problem. This could be a problem, and this can be considered malpractice. Okay? This could be considered negligence. Okay? So when you look at the subcostal, well, you don't know what the subcostal is. You don't know what a transverse is. You don't know what a McBurney is. You don't know what a groin is. A lower midline, a perimedium, and a penistenial. You don't know what these are. These are different ways that the surgeon can access an incision and access the organ. Different ways that there could be incisions for that on the patient. So that is extremely important in this case, right? So now, in surgical positioning, choosing the best position will provide the most accurate exposure to the surgical area, along with reducing the chance of injury to the patient. So when you are dealing with a patient, and depending on what this patient is coming in for, what procedure, you as a surgical technologist and everybody a part of the team should know the correct surgical positioning. So you have your supine position, you have your right lateral position, you have your flowers position, you have your prone position, your left lateral position, and your Trendelenburg position. Okay, all of which are required. Common surgical positions: the Trendelenburg position, the supine position, the prone position, the lateral position, the flowers position, and the lithotomy position. The four basic positions is supine, prone, lateral, and lithotomy. Variations include Trendelenburg, reverse Trendelenburg, flounders, jackknife, high lithotomy, and low lithotomy. Your surgical team positioning. So you also not only have to know your patient's positioning, but you need to know yours. You're going to always have more than one person in the operating room. Why? Why is that, little Desi? Well, I'm going to tell you why. You have to network when it comes to the operation. Things have to be able to flow like water, right? In the operating room, we all know that there is a operating table. We know that there's a patient. But did you know that there's other people in the room with you? Oh yeah. Not just you and the surgeon. You as the scrub nurse. But you have your anesthesiologist. You have your first assist, your second assist, okay? And sometimes your circulator, who is your registered nurse, who is also considered non-sterile. So as we continue into this topic, a patient was involved in a motor vehicle accident, an MVA. Remember that. While sitting in front seat passenger side and wearing a seatbelt, when the patient arrived at the emergency room, the patient noticed burning in the left upper quadrant. Uh-oh. There is a bruising in the left upper quadrant. Y'all see where this is going yet? The physician quickly inserted a needle with a syringe in the umbilical region and withdrew 10 milliliters of blood. The patient's vital signs were decreasing. The emergency room physician immediately called surgery department to notify them that a patient would soon be arriving. Question: what organs are in the left upper right quadrant? Right? So I need you to write that down. What organs are in the upper right quadrant? Well, first, do you even know what the left side is? Well, we just went over that. If you was paying attention, you would know. The left side will always be this side, right? So your left upper quadrant is over here, right? Right here. So what organs are in the left upper quadrant? Well, I know for certain your liver, your gallbladder, your pancreas, right? I'm just trying to see if you know. What is the most likely diagnosis? That's a good question. We're going to keep finding out. What organs are the umbilical region that the doctor would need to ensure were not penetrated by the needle? What organs are in the umbilical region that the doctor will need to ensure are not penetrated? So there's a lot of importance to knowing these things. So ask yourself why. Okay. Discuss specific elements of case planning for gastrointestinal surgery. Describe common techniques used in gastrointestinal surgery, including anastomosis and bowel technique. Discuss specific elements of case planning for surgery of the liver, biliary system, pancreas, and spleen. Describe specific elements of case planning for breast surgery. What is a hernia? A hernia is a protrusion of tissue through a defect or weakness in an abdominal wall. Okay? Strangulated hernia, a hernia, defected, strangulation, intestines. Why a repair? Why repair a hernia, right? Why do we need to repair a hernia? A herniated tissue may become trapped or encapsulated and possibly strangulated. Blood supply is comprised by the surrounding tissue. If the hernia is not reduced, removal of tissue from the defect, the blood supply to the tissue may be compromised and become necrotic. Dang, I can't talk. You know what that means? Dead. Necrotic. Dead. So when there's strangulation, there's no blood flow. That can cause necrotic death. Okay. Repairing a hernia. Well, this is the materials, right, that we said we were going to talk about. So there's mesh. And the mesh is like a web, not a web, a netted web, white web. Okay, and it's got like, it looks like a net, okay, but it's like square, and they use it in different aspects in surgeries for like a prolapse, uterus, bladders. They use them to pull them, to cause that tension to hold it up. So mesh provides a bridge of strong material over the weakening area of the abdominal wall. Made of synthetic material, e.g. Prolon, Dacron, and Meslin, or animal material. Mesh is available in sheets or patches that are fitted at the edge of the defect. They may come pre-cut or need to be cut to fit the defect, may be secured with suture or special staples for mesh, e.g. Pro-Tac. Okay. So this mesh can be used to become a bridge to draw in the intestine that is protruding up from out of the skin. I mean, yeah, like it's protruding up, you know, past the muscle and the fat, and it's causing this strangulation, right, of the intestine pouring out. So you can use this mesh to bridge it, and it can hold. So look, I'm the intestine, like this is me. I'm the intestine that's trying to come through, right? The hernia, blah blah. And so what we do is we take a patch of mesh and we place it into the abdomen, and we will put the intestine down with that mesh and then suture the incision closed. Okay, causing a repair with the mesh. Hernia types. So there's an incisional or ventral hernia. This is coming out from this is caused by an incompletely healed surgical wound, first and foremost, and often classified as a ventral hernias. Okay, so to remodel an abdominal wall scar to prevent a recurring of the hernia. So this is like, this will be a hernia coming out, this right here, up here, okay? You have an umbilical hernia. Completed to repair weakening of abdominal wall around and under, oh my goodness, umbilicus. This hernia is most common in children, usually disappears spontaneously by 2. In adults, in adults, this hernia appears more frequently in individuals with a high BMI. So this is where you see the belly button protruding outward, and it's really, it's not like a outie. Like you can tell that there's a discomfort, like an inflammation. Okay, so that's what it looks like. Okay, so this is a, how do you pronounce this word? Spindulum. What did he say?
Spigelium.
Spigelium hernia repair. Completed to reduce protrusion of abdominal viscera in what the fuck is the word? Spigelian zone. So this is a hernia that is going to be a little more towards the groin, but a little bit under the umbilical. So it's going to be right here, right down here. No, it's not. It's going to be like, yeah, right here. So it's a hernia. Oh, well, my body's different. So look, so it's like right here, and it's like kind of not near the groin. Don't cover me. All right. Perform to restore. Okay, the femoral hernia. Perform to restore strength to the inguinal floor and prevent abdominal tissue from protruding into the inguinal canal. This is a femoral hernia. Now, this is a hernia for the male and the female. So this is a female hernia because the female is a femoral, okay? And this is performed to restore strength in the inguinal floor and prevent abdominal tissue, okay? An inguinal hernia is for a male and is a direct or versus indirect hernia, okay? Incisional ventral hernia. Now, this is a hernia that we just said. So the abdominal scar is removed and the edges of the previous incision are trimmed. Why? Old sutures are removed. Why? Mesh may or may not be placed if there is an infection or the chance of infection occurring. So why is the incision edges trimmed?